Hello, and welcome to Pegasus Lectures educational series in obstetric and gynecologic sonography. My name is Jim Baughan, and in this module we will be reviewing gastrointestinal tract part 1. The embryology of the gastrointestinal tract begins early in gestation, and the primitive GI tract consists of 3 parts: the foregut, which will evolve into the esophagus, stomach, liver, biliary tract, pancreas, and part of the duodenum, receives its blood supply via the celiac artery and some of the branches off the aorta. The midgut will evolve into the distal duodenum, the jejunum, the proximal colon, and it derives its blood supply via the primitive superior mesenteric artery. And the hindgut, which will evolve into the distal colon, rectum, parts of the vagina and bladder, derive its blood supply via the inferior mesenteric artery. This schematic demonstrates the 3 portions of the embryonic gastrointestinal tract: the foregut receiving its blood supply via the celiac and some of the branches from the aorta, the midgut deriving its blood supply from the superior mesenteric artery, and the hindgut deriving its blood supply via the inferior mesenteric artery. Of importance is an understanding of the early fetal physiological herniation. In the embryo, and up till about 12 menstrual weeks, the abdominal cavity is filled predominantly by liver. There's no room for the gut to form within the fetal abdomen, so it herniates out into the base of the umbilical cord, where it begins its early development and rotational evolution. This is a normal finding. By about 12 weeks menstrual, the gut should have, the midgut herniation should have been reduced, and the gut should have returned to the fetal abdomen. This is important because with high-resolution ultrasound, it is possible up to 12 weeks to see this midgut herniation. It's imperative that early on that this not be confused with an anomalous herniation called omphalocele that will be seen later in pregnancy. So again, early on it's normal to see this. The image on the left demonstrates a traditional B-mode ultrasound image, sagittal scan through the early fetus with the head, anterior chest wall, and the herniation of gut into the base of the umbilical cord. This 3D surface rendering demonstrates the same thing, and the arrow is pointing to the presence of bowel in the base of the umbilical cord, a normal finding up until about 12 weeks. The liver occupies most of the upper abdomen in the embryo and in the fetus. It provides useful anatomic landmarks in evaluating the fetal abdomen. Recall that there are 4 vascular systems in the liver. There's the arterial supply via the hepatic artery. There is blood supply via the portal vein. About 75% of blood supply to the liver actually comes via the portal vein. There are the draining hepatic veins that drain into the inferior vena cava, and the biliary tract is also considered a type of vascular system, although it's not a blood vascular system. The anatomy of the portal vein, the draining veins in the portal sinus, is demonstrated in this slide. Blood arrives to the fetus via the umbilical vein. At the lower surface of the liver, it branches into an anastomosis with the portal vein into something that's called the portal sinus. The other branch of the umbilical vein courses through the liver and empties directly into the inferior vena cava. The hepatic veins, again, also empty into the inferior vena cava, and the combined fetal blood via the hepatic veins and the blood via the umbilical vein empty into the inferior vena cava and ultimately into the right atrium. This cross-section through the fetal abdomen demonstrates some of these normal anatomical landmarks. The upper abdomen is filled predominantly by liver, although we are seeing a fluid-filled stomach here. This is the vertebral body. This is the anterior surface of the abdomen. And we're seeing a nice cross-section through the aorta. The liver is here. And in the liver, we're seeing the umbilical vein as it enters the undersurface of the liver, as it connects with the anastomoses with the portal vein to form the portal sinus. We're also seeing adrenal gland as well. So this is the right lobe and the left lobe. The umbilical cord inserts on the anterior aspect of the fetal abdomen just above the urinary bladder. It's lower than our belly buttons, and in evaluating the fetus, it's important to remember that it would be found just above the urinary bladder, not in the mid-abdomen. As I mentioned, the umbilical vein brings oxygenated blood to the fetus, and at the confluence of the umbilical vein and the portal vein, the portal sinus is formed. As I mentioned, the ductus venosus empties directly into the IVC, and as we've seen, the portal vein and some of its branches. The umbilical arteries take deoxygenated blood away from the fetus and course inferiorly and lateral to the urinary bladder. They exit and enter the umbilical cord and take the blood to the placenta. This is an example of a normal cord insertion, a critical area to be routinely imaged on ultrasound because of the potential for some herniation defects that we'll talk about in just a minute. We see the umbilical cord here inserting on the fetal abdomen. We're seeing the vein and two arteries, fluid-filled stomach here. This color Doppler ultrasound demonstrates some of the vascular anatomy we just mentioned. The umbilical vein is seen here entering the undersurface of the liver as it anastomoses with the portal vein to form the portal sinus, and then it bifurcates into the main portal vein and the portal vein, the right portal vein. I'm sorry, the left portal vein and the right portal vein. This is a demonstration of the ductus venosus. It's a sagittal scan through the fetus. Chest is here, liver is here. We can see a bit of the portal vein there, and the arrow is pointing to the ductus venosus as it dumps directly into, traverses through the liver, and will empty into the IVC and then on into the right. The blood will flow on into the right heart. This is an example of normal paired umbilical arteries. As I mentioned, they course lateral to the urinary bladder, and the paired arteries will then exit the fetal abdomen, enter the umbilical cord, and take deoxygenated blood to the placenta. Umbilical cord Doppler is a non-invasive method of assessing the hemodynamic resistance of the placenta. It can be an indicator of fetal growth and development, and typically the methodology involves obtaining these signals in the cord in one of the arteries close to the placental insertion. Normal hemodynamic patterns of cord Doppler, umbilical artery Doppler, are the resistance decreases as gestation progresses. The placenta becomes more receptive to blood flow, less resistive as gestation continues. An abnormal Doppler demonstrates an increased resistance, the placenta resisting blood flow as gestation progresses, and this can be an indicator of placental insufficiency. It's one of the diagnostic criteria in looking at intrauterine growth restriction and assessing overall fetal well-being. This is an example of a normal cord Doppler. In this triplex image, we're seeing color Doppler, we're seeing the B-mode image, we're seeing the color Doppler image of the cord, and the range gate is right in here. Right in here. We're obtaining the spectral Doppler waveform that shows continuous forward flow throughout the cardiac cycle, indicating a fairly low resistance placenta. Some other normal fetal anatomical structures include these. Again, this is a coronal section through the fetal abdomen, demonstrating a urine-filled fetal bladder. The gallbladder from the on the undersurface of the liver, the main portal vein, liver. We're seeing the diaphragm, lung, and heart. Evaluation or identification Assessment of the fetal diaphragm is important in looking for certain other types of internal herniation defects, such as diaphragmatic hernia. A color Doppler evaluation of the aorta shows the main aorta and its bifurcation into the two iliac branches, and this is a nice demonstration of bilateral renal arteries. Of interest here is a normal duplication of the renal artery on the upside of this upside of the kidney. Again, some normal anatomy. We're seeing a not so full urinary bladder, a fluid-filled stomach, the heart, and again, we're looking to identify the diaphragm. The lung is seen here. Fetal bowel normally is less echogenic than adjacent skeletal structures, but usually more echogenic than adjacent parenchymal organs such as the liver and the spleen. This is a nice demonstration as well as the difference in echogenicity between normal lung and liver and bowel. We'll discuss two types of external herniation abnormalities. Two main types, and then there are two other lesser common types. We'll review omphalocele, gastroschisis, limb body wall complex, and cloacal exstrophy. Omphalocele and gastroschisis are the two most common types of external herniation. An omphalocele consists of the herniation of abdominal contents through a midline defect in the abdominal wall. It results from failed reduction of the midgut hernia that I just mentioned. And the herniated contents typically include liver, but it may include a variety of abdominal anatomic structures. The differentiating signs in an omphalocele to differentiate it from a gastroschisis is that the herniated contents are covered by a layer of amniotic epithelium. There's a membrane surrounding the herniated contents, and these herniation defects occur at the level of the cord insertion. Important differentiators: membrane at the level of the cord insertion. This defect is also frequently associated with various other anomalies and genetic syndromes. So when an omphalocele is identified, a very thorough, detailed examination of fetal anatomy should be performed. Sonographic findings will demonstrate an extra-abdominal mass containing a combination of intra-abdominal contents. There may be fluid-filled bowel loops, mesentery, omentum, and sometimes the liver, pancreas, spleen may also herniate into the base of the cord. The ultrasound finding will demonstrate that this mass is contiguous with the umbilical cord, and a membranous sac will be seen covering the herniated organs. Also, because a lot of the bulk of intra-abdominal anatomy is herniated out, the abdominal circumference measurements will be less than expected, and frequently polyhydramnios will be seen in association with an omphalocele. The schematic demonstrates an omphalocele, a herniated abdominal contents covered by a membrane into the base of the cord, so it's at the level of the cord insertion. The sonogram demonstrates a small fetal abdomen, a cross-section through the fetal abdomen, and we're seeing this large, complex mass protruding from a defect in the anterior abdominal wall. Within it, we're seeing bowel loops and other structures that are not identifiable, but it's of importance is that we're seeing the membrane that surrounds the herniated contents. This is another example of an omphalocele. We're seeing the spine, a cross-section through the fetal abdomen. We can see the stomach just beginning to pooch out into the base, into this herniated defect. The entire liver, with the portal vein seen inside it, is herniated into this, through a abdominal wall defect, into this herniation defect that is covered by a membrane. Again, hallmarks of an omphalocele. A gastroschisis is also an anterior abdominal wall defect through which abdominal contents herniate. However, it is usually located adjacent to the cord insertion, and it is not covered by a membranous sac. The etiology is uncertain, but it's thought that perhaps ischemic insult to the anterior abdominal musculature may result in this cleft in the abdominal wall. Unlike omphalocele, which is frequently associated with other anomalous conditions, gastroschisis is usually a solo defect. Sonographic findings include the presence usually of thick-walled loops of bowel seen extending into the amniotic cavity and sometimes free-floating in the amniotic cavity. The cord is identified adjacent to the defect. There is no membranous sac covering the herniated contents, and also for the same reason, the abdominal circumference measurements will be less than expected. The schematic demonstrates the herniation of bowel loops from a defect in the anterior abdominal wall adjacent to the cord insertion. This ultrasound image demonstrates close-up through the anterior abdominal wall, and we're seeing the umbilical vein here, and we're seeing these free-floating loops of bowel. And note that this is adjacent to, the umbilical vein is adjacent to the bowel, and there is no membrane covering the herniated bowel. This image demonstrates nicely the gastroschisis, the herniated bowel adjacent to, not at the base of the cord, adjacent to the umbilical cord. No membrane covering the herniated bowel. Limb body wall complex is rare. It's a lethal constellation of disruptive anterior abdominal wall anomalies. It's also a form of abdominoschisis, which means the exteriorization of abdominal contents. The umbilical cord is absent, and the contents are attached directly to the placenta. There's no cord in between. It's also sometimes referred to as body stalk anomaly. The schematic demonstrates the exteriorization of abdominal contents that attach directly to the placenta. Sonographically, the fetus appears tethered to the placenta. There is a very short or no umbilical cord identified. The liver and abdominal viscera are seen to herniate outside of the abdomen. There's no membrane present, and there's no free-floating umbilical cord identified in other locations within the amniotic cavity. The sonographic appearance is dramatic. It's dramatically abnormal. This is a section demonstrating a fetus tethered to the placenta. We see the head up here, fetal thorax, and the abdominal contents exteriorized, herniated out, and attaching directly to the placenta. This is another example of a body wall complex. We're seeing the placenta here. There is a little teeny short segment of cord seen, the arrow is pointing to, and we're seeing bowel herniated outside the fetal abdomen and tethered directly to the placenta. Cloacal exstrophy is a rare association of anomalies arising from the abnormal embryologic development of the cloaca, the primitive anus and urethra area, perineal area. It's caused by the embryonic disruption in cloacal development, and it results in incomplete closure of the inferior part of the lower abdominal wall. There are a triad of congenital anomalies, and they include a lower abdominal wall defect, exstrophy of the bladder, that is exteriorization of the bladder, and an omphalocele. Associated abnormalities are many. They include multicystic dysplastic kidney, hydronephrosis, undescended testicles, cleft clitoris, or epispadias. Sonographic findings include not identifying a urine-filled bladder over 30 minutes of scanning, the exteriorization of the bladder, and in some cases, the presence of a microphallus. And here we're seeing an example of cloacal exstrophy. This is the anterior abdominal wall. This is inferior, and this is superior. And we're seeing the triad, some of the symptoms. We're seeing the exteriorization of the bladder and an bladder here, anterior abdominal wall, omphalocele. I hope that this first module, an evaluation of the fetal GI tract, will be useful to you in your practice. Thank you.